This is a 26-year-old female presented with jaundice.
دعاء الصوت ماكو.
تسمعوني؟
اي شوي على الصوت.
This is a 26-year-old female with jaundice.
بعيد الصوت بعيد.
عم يكسر زين؟
هسه كل زين.
تمام. This is a 26-year-old female presented with jaundice.
نعم. 26.
بلي 26.
نعم.
This is the coronal image. This is the X-ray.
RCP.
حضرتك نفس البوست كونتراست.
اوكي عشان
هذا بري بوست كونتراست.
نعم. اوكي MRCP ما سويتوا لها دكتورة؟
لسه طلع بالصورة.
عاشت ايدك.
اكبر الاشياء انا حطيتها ويا المب.
ماكو مشكلة، لا ان شاء الله خير.
هاي السيكونس الموجودة دكتور.
اوكي. multiple sections T2 و T1 or post contrast with MRCP showing hepatomegaly with multiple cystic lesion occupying different loops of the liver, mainly the left, also the right loop, and one inside the peritoneal cavity, cystic with internal cystic lesions, cyst with daughter cyst mainly. Mainly in the left loop, and also there is I noticed dilated hepatic CBD with left hepatic duct mainly occupying also by the multiple cystic lesion. The CBD, the right hepatic duct كمان normal. I see it post contrast, no enhancement post contrast, ماخذ peripheral enhancement, the region take peripheral enhancement. No free fluid inside the abdomen, but also there is a multiple cystic lesion also in the abdomen. Mainly I see it in the retroperitoneal structure. So we deal with the multiple cystic lesion occupying the liver and also in the retroperitoneal structure. ما أعرف هيك extensive وهيك cyst. أول شيء يجيب بالي هو hydatid اللي هو multiple rupture hydatid cyst. وهي صح فيميال نقدر نخلي differential لها biliary cystadinoma بس ما تجي هنا، تجي بالرايت لوب of the liver تاخذ انهانسمنت السبتة، هاي السبتة ما ماخذة انهانسمنت، هي مالتيبل يعني بالضبط دوتر سيست، مالتيبل دوتر سيست او ما يسمى كوغويل ابييرنس او سبوكتويل ابييرنس، هي هذه يعني الدايليتد مال ليفت يعني mainly left hepatic duct with inside there is multiple cystic lesion and also من يعني till the hilum يعني mainly there is يعني rupture يعني احتمال انه rupture مال hydatid cyst within the intrabiliary cystic system.
الخطوة الثانية شو الطلبي للمريض؟
نعم عمو؟
الخطوة الثانية شو الطلبي له؟
سي تي chest.
ليش سيتي؟
يعني او اكس راي chest، يعني انه المينلي هو الهايداتد ديزيز هو يعني 75% يصير بالليفر ويصير 50% باللنج اللي هو السكند اورجن.
اذا ليش شو اسمه ليش سيتي؟ خذ تشيست اكس راي كافي.
chest x-ray نعم. يعني one of them showing يعني rupture membrane، يعني I see water lily sign mainly in the right، كان اكو وحده بالرايت هم اكو بيها water lily sign يعني partial rupture، يعني هاي نعطيها مال WHO، اذا نمشي على WHO فهاي CEA 3 اللي هي يعني cyst within daughter cyst يعتبروها، اللي هي active stage، اللي هاي نخاف من عندها. اذا صارت rupture ودخلت باي سيستم يعني هاي يصير بها dissemination، فيعني هاي CA3 مو الانكتيف، لا هاي الاكتيف اللي هو ستيج 3.
صحيح. زين اكو اسايتس؟
مايلد يعني مينلي بالسب هيباتيك سبيس صاير يعني بالموريزون بوتش يعني تقريبا.
صح. شكرا جزيلا دكتور هدى.
عفوا.
دكتورة هدى زوري.
السلام عليكم عمي.
شلونك؟
الحمد لله الحمد لله.
Your opinion بابا.
والله عمي مثل ما تفضل الدكتورة بلسم انه انا شفت انه هي هاي فد مالتيبل سيستيك ليجن انفولف هول يعني البريتونيال ريتروبريتونيال الليفر مينلي الليفت سايد with intracystic lesion representing daughter cyst، فانه هي شكلها مال هايدات السيست ومينلي انه هي rupture especially للليفت هيباتيك انترا هيباتيك داكت، سويت لها دايليتيشن. الرايت حسيتها انه اوكي ما بيها مشكله، بس المشكله اكثر شيء بالليفت سايد، فانه هاي تمشي انه اكثر شيء ويا الربتشر هيباتيك سيست.
زين تقدرين تقولين ال WHO كلاسيفيكيشن على السريع مال الهايداتي؟
والله عمو ما ادري، بس انا اتذكر هو الاكتيف ستيج هو ستيج 3، يعني انه هي اتذكرها انه هي هاي مينلي انه نحن نخاف من عندها على مود انه هي اكتيف اكثر شيء اكتيف.
بس هاي تتذكري.
اي واللي انه هي تقريبا انه احنا نتوقع انه الهيباتيك انه يتربتشر اكثر من 50 او 90% نتوقع انه يصير بيها ربتشر، واكثر شيء نفكر به انه هو يصير وياه الاسوشيت تشيست، فلازم احنا اول شيء نشوف التشيست وياه.
شكرا هدى. دكتور اوس. دكتور اوس.
نعم أستاذ، السلام عليكم.
صباح الخير.
صباح النور أستاذ.
تقدر تعرف ال WHO كلاسيفيكيشن مال هايداتي؟
والله أستاذ هو عندنا 5 كلاسيفيكيشنز، ال1 السي 1 أو تايب 1 يكون يونيلوكولار سيست، والتايب 2 يكون مالتي سبتيتد سيست، هذين يكونون اكتف. اكو تايب 3 او سي 3 سيست with the daughter cyst، واكو تايب 4 و5. تايب 4 يصير سيست with heterogeneous يعني hypoechoic و hyperechoic contents mixed، واكو اخر شيء تايب 5 اللي يصير solid content cyst، عاده يكون inactive.
شكرا اوس. شكرا.
الله يسلمك.
اذا نرجع على دكتوره دعاء عبد الحميد، احكي لنا بابا على الكيس واذا مسويتوك حتى تروحي.
اي نعم. البيشنت هي 26-year-old female presented with obstructive jaundice. She was a non-case of hydatid cyst. When we
الصوت ضعيف بابا، الصوت ضعيف بنتي.
هسه اوكي عمي؟
ايه هسه اوكي.
تمام. هي 26-year-old female presented with obstructive jaundice. She is a non-case of hydatid cyst. Multiple cystic lesion in the liver was seen with multiple daughter cysts. The interesting finding in this case was the presence of a dilated left hepatic duct and CBD, as you can see in this T2 weighted image. Here you can see the dilated left hepatic duct and the CBD with the presence of debris within the ducts. Raise the possibility of intrabiliary rupture of the hydatid cyst since the patient presented with obstructive jaundice. So there's something obstructing the biliary system. You can see here in the post-contrast study, in this axial section, it was obvious how the CBD is dilated. And then the patient, after 4 days, presented to our department, to the MRI department, for another follow-up study after the ERCP. So this is another study 4 days after the previous one. You can see how the image is completely different. The pressure is relieved. The multiple cystic lesions were clearly seen, but there was no dilatation of the left hepatic duct or the CBD. This is another image.
سووا لها بالاي ار سي بي.
دكتور بالاي ار سي بي داخلين عن طريق السي بي دي وشايفين انه اكو مالتيبل هايداتد سيست صغار مطلعيها بالون سويب يعني ومطلعيها. they relieve the obstruction.
شلون مطلعيها؟
قالوا انه يسوون بالون سويب، يدخلون بالون ويسوون سويبنج للماتيريال.
وبعد شو يسوون؟
هم دكتور قالوا كل شيء ما تسوين بس هيك.
سفكتروتومي ما يسوون؟
دكتور ما قالوا، انا حتى عندي الريبورت مال الاي ار سي بي ارويح حتى بالتوك حاطين.
لا هي بس المفروض يسوون سفكتروتومي لانه احتمال اذر دوتر سيست تكبر وهم يسوي ابسكشن. بعد ما اعرف هم مسوين بس بالون سويب، ما اعرف يعني. على كل
مسوين بس البالون سويب. هاي بس حتى ارويكم الفرق بين الايمج القديمه والايمج الجديده. But what was interesting about this case, after the ERCP and after the relieving of the obstruction, the patient developed bilateral lower leg swelling, lower limb swelling. The whole lower limbs were bilaterally swollen. They sent her for Doppler study. There were no signs of DVT. So they were thinking of IVC obstruction. And after the revision of the study, it was obvious that there is an IVC compression caused by one of the hepatic lesions. You can see this in the image. And at this section, there is an IVC compression. So the patient will undergo another surgery to relieve this obstruction.
هذا كلش complicated هذا خطية. وبعد شو يسووا له هذا غير الاي في سي ريليز؟
هم يمشون step by step انه بس to symptomatic treatment. When there was an obstructive jaundice, they relieved the CBD obstruction, and now they will go to relieve the IVC pressure. لأن هي extensive وأكو intraperitoneal lesion فممكن يصير أكو spillage و more spread.
هي فيميل مو؟
young female.
زين هاي شنو بالبريست ليجن بالليفت؟ بالكورونال على اليسار الصورة. بالتشيست وول بالبريست. لا هذا شنو هذا؟
دكتور هي أصلاً كل شيء يعني thin كتشكسك ومش عملها هذا complaints.
أوكي. سويتوك؟
نعم دكتور.
يلا خلينا نروح على
واضح عندكم دكتور؟
بل واضح.
This is the ERCP report of our patient. It was documented that multiple hydatid cysts were seen within the CBD and biliary balloon sweep was done to relieve the obstruction. My talk will be about the spectrum of a multilocular cystic hepatic lesion. because the presence of a multilocular cystic hepatic lesion is a common finding on CT and MRI, and it has a list of differential diagnoses. Sometimes we can find some suspicious features within the multilocular cystic lesion, like mural nodularity, irregular thickness of the septa, ragged inner surface, and typical enhancement of a solid component. Those might raise the possibility of the presence of a primary or secondary malignant tumors, although they are uncommon to be cystic to present as multilocular cystic mass. We have to think of the more common infectious processes like the hydatid cyst and abscess. For the definition of the cystic lesion, it's a lesion with water attenuation on CT from 0 to 30 Huntsfield unit and fluid signal intensity on MRI with negligible enhancement, of course. Sometimes the density or intensity will be slightly higher than the pure water because of the presence of different amounts of and composition of fluids. The cystic components may be secondary to liquid substances like the serous, mucinous, or hemorrhagic fluids, or due to intratumoral necrosis, or sometimes tissue with high water content. The differential diagnosis of a multilocular cystic hepatic lesion would include the neoplasms, including biliary cystadenoma and cystadenocarcinoma, hepatocellular carcinoma, metastasis, and mesenchymal hamartoma. The infections would include pyogenic abscess and hydatid cysts, and we have to think of the possibility of injuries like hematoma or myeloma if the history can point toward this diagnosis. Regarding biliary cystadenoma and cystadenocarcinoma, those are rare neoplasms of the biliary system, most commonly present within the intrahepatic bile ducts, 85%, in middle-aged female. At imaging, they will appear as a large, solitary, multilocular cystic lesion with a smooth margin and internal septa. And of course, there is enhancement of the wall and septa. The differentiation between cystadenoma and cystadenocarcinoma based on imaging only is very difficult, although there are some features that can point toward the transformation, like the presence of hemorrhagic fluid, solid mural nodule, or coarse calcification. This is a case of biliary cystadenoma in a 42-year-old female, showing the multilocular cystic lesion with enhancing septa. This is another example on MRI of a biliary cystadenoma, showing a T2 and post-contrast study, showing a multilocular cystic lesion within the left lobe of the liver, with adjacent dilatation of the intrahepatic biliary radicals. Regarding hepatocellular carcinoma, it can present in any radiological appearance, so we have to think of it. It sometimes presents as a heterogeneous architecture, the mosaic pattern. It can undergo extensive amounts of necrosis, so it presents like a multilocular cystic lesion. As you can see in this image, this is a patient having a mass in the liver, multilocular with septa, multiple septa. This is the same patient, but the sections were slightly superior to the previous one, showing the presence of solid nodule, taking an early arterial enhancement in the arterial phase and showing washout in the delayed phase. So it was confirmed that this is a hepatocellular carcinoma in a 65-year-old female in a history of hepatitis B liver cirrhosis. Metastasis, we know that there is a cystic metastasis, usually present with areas of liquid attenuation with negligible enhancement. They are much less common than the hypovascular and hypervascular metastasis. Cystic metastasis can result either from the necrosis of hypervascular metastases due to rapid growth, such as those from the neuroendocrine tumors, melanoma, or GIST, or due to abundant mucin production from adenocarcinoma like colorectal or ovarian adenocarcinoma. This is an example of a metastatic gastrinoma in the pancreas of a 39-year-old female, the CT showing multiple multilocular cystic lesions within the liver. And this is another example of cystic liver metastasis originated from an ovarian granulosa cell tumor in a 62-year-old female patient, showing a multilocular cystic lesion with a solid component taking enhancement. Mesenchymal hamartoma, it's a rare type of neoplasm, but it is the second most common benign hepatic tumor in children after infantile hemangioendothelioma, usually occur in male children younger than 2 years of age. It's considered as a developmental anomaly. It's a hamartoma, so disorganized tissue, containing varying amounts of cystic and soft tissue components. but the dominant feature will be a large, often around 12 to 15 cm, predominantly cystic mass with internal septation. As you can see in this image, this is a mesenchymal hamartoma in a 28-month-old boy showing a very large multi-septated mass causing compression and displacement on the major abdominal vessels. Those were the neoplasms. Regarding the hematoma, when there is a history of surgical procedure or sometimes blunt trauma, hemorrhage in a patient with coagulopathy, or rupture of a primary hypervascular neoplasm, we might think of a hematoma. CT, of course, is very useful. In the acute phase, they will contain a high attenuation from 40 to 60 Hounsfield units, representing the clotted blood surrounded by the unclotted blood and bile, while in the chronic stage, they will appear as a well-defined cystic fluid collection. This is an example of an intrahepatic hematoma in a 35-year-old female. In the acute phase, there is a hyperdense material within a multilocular cystic lesion showing different attenuations, while in the chronic stage, after the follow-up, there is a well-defined cystic lesion, smaller even in size. Regarding the infectious processes, we have the pyogenic abscess and the hydatid cyst, of course. The abscess is a localized collection of pus in the liver. The majority are pyogenic, followed by the fungal and amoebic. The important is that the pyogenic and amoebic both can present as a multilocular cystic lesion composed of fluid attenuation. This is an example of a pyogenic liver abscess in a 44-year-old man, showing what is called the double target sign. The center is hypoattenuating, the peripheral is hyperattenuating, and then you can see that there is a very thin line of hypoattenuation on the outer surface. This is what's called the double target sign. This is another example of a pyogenic liver abscess. You can see that the T2 weighted image and the fat saturation post-contrast study, showing the lesion, multilocular cystic lesion with a fluid signal intensity and showing intense enhancement of the internal septa. Regarding the hydatid cyst, which is the subject of our study, it's very common in the endemic areas. It can result from the infection of the larval form of Echinococcus tapeworm, and the liver is the most frequently infected organ, of course, followed by the lung and spleen. It enters the body through the ingestion of contaminated water and food, and then pass to the liver through the portal vein. They can rupture into the peritoneal cavity, bile duct, pleural cavity, or retroperitoneal space. The leakage of the fluid can result in anaphylaxis, eosinophilia, or sometimes anaphylactic shock. The hepatic cyst can present in many ways. It could be solitary or multiple, can sometimes present as a pure cyst, in the spectrum up to heterogeneous mass. So there is a WHO classification of the hepatic hydatid cyst. This classification is based on the ultrasound finding mainly. We have 5 stages. CE, it stands for a cystic echinococcus. So CE1, it's an active stage present with a unilocular and echoic cyst, sometimes containing fine internal echoes after patient repositioning, as you can see in this ultrasound image. CE2 is also an active stage. It represents the presence of daughter cysts. So they will appear as a multivesicular rosette or honeycomb appearance, as you can see in this ultrasound image. CE3, it's a transitional stage, and it stands for the evolving appearance of the daughter cyst. It has 2 subtypes. 3A, the presence of laminated membrane, as in this image, and the 3B, the presence of daughter cyst within a solid matrix. Those stages considered as transitional stages. We have CE4, it's an inactive stage, present as a heterogeneous hypo and hyperechoic mass resembling the ball of wool. So it's called the ball of wool sign. And CE5 is an inactive stage, represent with the partial or complete calcified wall, as you can see in this image. Regarding the CT, typically they will appear as a multilocular cystic lesion, as you can see in this image, with peripherally located daughter cyst, Usually the density of the mother or parent cyst is higher than the daughter cyst because of the presence of hydatid sand and detached membranes. On MRI, they will appear, of course, they are cysts, they will appear hyperintense on T2 and hypointense on T1. Sometimes they can be mixed on T1 because of the presence of a proteinaceous material. You can see in this image, the patient have a hepatic and pulmonary hydatid cyst within the liver and the lung, multilocular cystic lesion. Both on CT and MRI, the hydatid cyst can take enhancement in the wall and in the septa. Regarding the intrabiliary rupture of the liver hydatid cyst, which was the scenario in our case, it's one of the most frequent complications of hepatic hydatid disease. It's reported in about 6 to 17% of cases, but some authors state that it can be seen in up to 25% of cases. The radiological features divided into direct signs and indirect signs. The direct sign is, of course, the direct visualization of the communication between the cyst and the biliary system, while the indirect signs include a break in the cyst wall adjacent to a bile duct, biliary tree dilatation, sometimes the distorted shape of the cyst representing the low pressure due to rupture, displacement of bile ducts due to extrinsic pressure, presence of gas fluid or fatty fluid within the cyst itself, and beak-like projection of the cyst wall. In this image, you can see clearly that there is a communication between the cystic hepatic lesion and the biliary radicals. There is also a small amount of hypointensity within the duct representing the presence of hydatid material. This is confirmed to be a surgically confirmed to be a biliary rupture. And this image represents the presence of an indirect sign of rupture without the presence of rupture. You can see that there is a multilocular cystic hepatic lesion with a massive dilatation of the intrahepatic biliary radicals that can point toward the presence of intrabiliary rupture, but there was no rupture. So we have to make sure that even the presence of an indirect sign is not a guarantee for the diagnosis, and we have to assess the integrity of the pericyst itself. And those are the references. Thank you.